So good afternoon and welcome everyone. I'm Jean Witowski-Wendy and I'm Dean of the School of Public Health and Health Professions at the University of Buffalo. I welcome you to the 34th annual J. Warren Perry Lecture. This lecture honors J. Warren Perry, PhD, who was the first dean of the School of Health-Related Professions at the State University of New York at Buffalo. Dr. Perry, who was one of the pioneers in the field of allied health, served as dean from 1966 until his retirement in 1977. In 1989, the current dean, Alan Stahl, initiated this lecture and this lecture series to honor Warren with an event that would introduce school faculty, students, staff, and alumni to some of the best scholars in the health sciences in the nation. In January 2003, the School of Public Health and Health Professions was formally established by combining the current Department of Epidemiology and Environmental Health and the School of Health-Related Profession. Our school grew into now 5 departments, which includes biostatistics, community health and health behavior, epidemiology and environmental health, exercise and nutrition sciences, and rehabilitation science. Our school was awarded full accreditation as a School of Public Health in 2009 and was reaccredited in June of 2015 by CEF, the Council on Education for Public Health. In addition to our accreditation as a School of Public Health, we have additional national accreditation in dietetics, occupational therapy, physical therapy, and athletic training. Among the members of the American Schools and Programs in Public Health, our school is just one of a handful in the country that includes both public health and health professions. At this time, I'm pleased to introduce Dr. Lorraine Collins, who is our Associate Dean for Research in the school, who will introduce today's Perry lecturer, Dr. Rosalie Pacula.
Hello, everyone. It's my pleasure to introduce Dr. Rosalie Pacula, or Pacula. Dr. Pacula is the endowed Elizabeth Garrett Professor of Health Policy, Economics, and Law in the Department of Health Policy and Management at the Sol Price School of Public Policy and Research, as well as a senior fellow at the Leonard D. Schaefer Center for Health Policy and Economics, both located at the University of Southern California. Over the past 2 decades, Dr. Pacula's research has focused on issues related to illegal and imperfect markets in areas such as healthcare, insurance, and illicit drugs. Specific to addictive behavior, she studied the supply and demand of illegal drugs that are used recreationally, including opiates and cannabis. Other research topics have included prescription drug misuse among the military, barriers to the diffusion of buprenorphine for treating heroin misuse, and evaluating the effectiveness of alcohol prevention and treatment strategies. In 2003, she was well ahead of the field in publishing the book, Cannabis Use and Dependence, Public Health and Public Policy, which focused on marijuana markets. In some ways, we've come a long way since 2003, and in other ways, as we've been discussing, we've barely added to the research that's needed. Among Dr. Pacula's many federally funded research projects, she has studied topics such as evaluation of the impact of medical marijuana policies on the consumption of cannabis, as well as public health harms associated with recreational marijuana. Dr. Pacula earned a Bachelor of Science in Economics and Political Science from Santa Clara University and a PhD in Economics from Duke University. Prior to her current positions, highlights of Dr. Pacula's career in academia include being a professor in the Pardee Rand Graduate School in Santa Monica, California, senior economist and director, the Bing Center of Health Economics, co-director of the Drug Policy Research Center at RAND. Dr. Pacula has a stellar record of publications in high-quality journals and has served on several editorial boards. Basically, she's nationally and internationally renowned. She's a member of the National Bureau of Economics Research, and currently she serves as the president of the International Society for the Study of Drug Policy. Please join me in welcoming Dr. Pacula as she presents on the impact of policy on public health, evidence from cannabis legalization experiments in the US and Canada. And now I turn it over to our presenter.
Well, thank you so much, Dr. Collins. It's really an honor and a pleasure to be here. And now I understand why I am so tired after hearing what I've actually been doing. You forget when you just get through it. So as was already mentioned, I should do it this way, the keyboard. This is work that I have been doing for many years. And as such, I have to recognize the contributions of many of my colleagues that I've had the pleasure to work with, both at RAND, at USC, and in Australia and Canada, and University of Colorado. I have the long list here and a lot of the important intellectual insights come from this very large team of people with a lot of support from the National Institute of Drug Abuse that we're very grateful for. As many people are aware, U.S. has been experiencing substantial variation in the state cannabis laws over the past 25 years. And while there's been a great focus on the laws recently related to medical and recreational policies, it's important to also keep in mind that innovation in state cannabis laws actually started back when in the 1970s, when cannabis initially got scheduled as a Schedule I drug in our Controlled Substance Act. And since then, and almost immediately following that, 11 states thought, no, this is way too severe. Scheduling for cannabis, it's inappropriate, and immediately decriminalize the possession of up to small amounts of cannabis. Small is a relative term. It can vary from anywhere between 10 grams to an ounce to up to 2.5 ounces across the states. But today, that variation still exists in terms of the legal penalties that people face when caught in possession of cannabis in a decriminalized state versus the allowance for a limited or broad supply chain for cannabis, which is what is unique about our medical and our recreational laws. In the case of medical cannabis, it's the allowance of a supply chain and retail stores that distribute cannabis for medicinal purposes to people who have identified either through a state registry or through a card as a medical user, or in states that have gone further in adopting policies and allow for adult use, are often referred to as recreational cannabis. These are supply chains that provide access to anyone over the age of 21 for their own purposes to use as they choose. This variation in policy is actually quite diverse across the states, which is part of the reason why it's really difficult. A lot of researchers go, great, there's cross-state variation, that's perfect for doing natural experiments. But sometimes those natural experiments aren't as well defined as what you would like for a scientific evaluation. And that's part of what I want to hope to convey through the talk that I'm going to be giving to you today. First, the complexity of policy and trying to do these sort of evaluations. And then secondly, the complexity of the object of these policies, cannabis. Cannabis is a plant that has more than 120 now identified cannabinoids. So a complex mix of different components, and those are just cannabinoids. There's terpenes and other flavonoids, other aspects of the plant that can change the experience of the user, not necessarily the impairment of the user, but sometimes the experience of the user, and has for centuries been used as a medicine in many cultures. But that plant itself is complex, and that plant has changed. And that plant has changed in many respects because of the policy environment that has emerged in the US, which is another point I hope to make clear today. So with all the policy variation and both the benefits and potential risks of cannabis, and we'll talk about some of what those are, there's been a lot of interest in understanding how our policy variation that has occurred over the last 25, I say 50 years, has really influenced a range of public health and social impacts in our society. And that's what I'm here to talk about today. Keep going back to the old one. Let me start by saying the changes in cannabis policy, decriminalization, medicalization, and more importantly, adult use recreational, has had some important strengths to help society that do have public health impacts. And the most significant of those is the reduction in criminal justice costs and arrests that get imposed on some individuals simply because of using, others because of possession with the intent to sell, and others for the actual sales. A really valuable study that was done in 2019 was trying to quantify what's the additional gains in reductions of arrests for marijuana possession associated with different types of policy changes in the US. This is a study by Plunk et al., published in JAMA Pediatrics. And what was really fascinating to learn from this study is states that had legalized cannabis for adult use, those over the age of 21, did have significant reductions in adult arrest possessions, as expected and intended by the law, but there was only modest declines in arrests for youth because no state has legalized cannabis for youth. And thus any existing prohibition that could exist on possession offenses can still be applied to youth. A more important policy for influencing the criminal justice costs associated with possession of cannabis is really decriminalization, which has impacted arrest rates for both adults and youth over time. These are event study analyses that show the changes in arrest rates. These negatives are the negative 3 years before the policy is adopted, 2 years before the policy is adopted, 1 year. There's been a general decline in recent years in possession offenses, leading to arrests because of a whole bunch of broader criminal justice changes. But post-adoption of decriminalization, you see an immediate drop for both youth and adults in the risk of arrest that you don't see with legalization. And when you compare this to states that have not passed either of these policies, you see that both decriminalization and legalization can generate a reduction in the criminal justice costs associated with marijuana possession, which has a number of both social benefits as well as public health benefits, because we all know that jails are not a very good place, not a very healthy place for those who have to spend extended periods of time there. The state systems that have been adopted have also generated, both through the medical laws as well as through the recreational laws, new jobs and tax revenue. As of January 2022, the cannabis industry claims that they've created nearly 500,000 new jobs by the creation of these supply chain markets. Sales in 2021, according to the industry, was over $27 billion and generated just $4 billion in tax revenue in 1 year alone last year. So this is substantial revenue to states. Previously, this money was what these exchanges were likely to be happening. We don't know at what level entirely, but in the illicit market where there was no benefit to the economies, to jobs, to governments. And so the transition of these markets from the illicit to the legal market has had some very clear strengths for society. But it's also important to bear in mind that the regulatory systems that we have set up here in the US states also have some weaknesses and some downsides that need to be considered, particularly as we have discussions about federal legalization. First and foremost, none of the current regulatory systems, medical or recreational adult use in the US, have eliminated the illicit markets. And in fact, it's important to know that both in Uruguay, where they have legal cannabis being sold in pharmacies as well as social clubs, and people are allowed to home grow, they just have to identify their source of supply. They have one of those 3 options. Even in that market, they have still illicit markets emerging for cannabis. Is that a problem? A lot of the states that adopted policies in the US did so with the explicit purpose of trying to eliminate the illicit market. I would argue that that is really not an achievable goal. And the reason why is we have illicit markets today in tobacco. We have illicit markets today in perfume, in prescription drugs, in a whole host, purses, sunglasses. We have a range of illicit markets for a variety of different products, the safety of which vary. You can examine, purses and sunglasses as not potentially harmful to someone's health. It's just taking away revenue from legitimate businesses. But I would argue cigarettes and pharmaceuticals that are traded in the illicit market, and you can't get much more regulated than the pharmaceutical market in the US, you still have an illicit market. So a goal of eliminating the illicit market, I think, is unrealistic. I think the goal is to try to create a safe, known product that people can trust and have it sold in a legitimate store where they can purchase it in a safe way and use it in a way that the user is informed of both the benefits as well as the potential risks if they use it in a manner that's not appropriate for their own health. So it's important to keep in mind illicit markets are not going to disappear with legalization, and that's not a realistic goal, but it is possible to try to generate a safe product. And it's also possible to set up a system, a regulatory system that encourages moderate, low potency use that people can enjoy and have the benefits of the product, whether medicinally or recreationally, without the risk of unknown, unintended consequences because the product isn't safe or it's of unknown potency. How do we achieve this, and why is this important? I will argue that it hasn't really been achieved by our current markets, and some of the other regulatory environments outside the US are perhaps a little bit better, but it's really important to understand what the market looks like today versus where it started before medical cannabis policies, the first implementation of the supply chain emerged. What I'm showing you here is a graph of illicitly seized cannabis plants by US law enforcement that's then sent to the University of Mississippi for investigation of its ingredients. And what I show you here in the red line is the potency of this illicitly law enforcement obtained cannabis, the trend in THC starting in 1995, where the average potency of illicitly seized cannabis was just below 4% THC, growing over time 2019 to now where the illicitly obtained cannabis sold in illicit markets, the typical THC seized is just under 15%. This is more than a threefold increase in THC. At the same time, the blue line is showing you the percent of CBD. THC, I should say, is the main psychoactive ingredient in cannabis. There's different variants of THC, as we are now learning, but it's the main ingredient that we think of when we think of the potency because it's what causes greater impairment. CBD is a different cannabinoid inside the cannabis plant that is believed to have a number of different therapeutic benefits, has naturally occurs in the plant, and in some variants of the plants is actually slightly lower, but on par with THC in the naturally occurring plant. Research has suggested that variants of cannabis where the CBD is on the same level as the THC in terms of the amount of milligrams or percent of the cannabinoid, that it actually helps offset the impairment caused by THC, and thus might be a beneficial additive part of the plant and why it was used effectively as medicine for so long. What this graph shows is that while initially with medical cannabis laws starting to pass in 1996, illicitly seized cannabis initially saw a rise in the rate of CBD in the cannabis plant, but still well below. While the blue line is above the red line, the percent CBD is here on the far right axis, not the left axis. And then it started to decline precipitously as the cannabis market became more and more competitive and commercialized, even in the medical market. Today, the difference between THC and CBD is substantially larger than what we observe in the naturally occurring plant. This is what's happening in cannabis obtained illicitly. Even in legal markets, what I'm showing you now here is data from Washington State's seed-to-sale system for the period when they opened the stores in 2014 through 2019. This was a study that was done by Stephen Davenport as part of his dissertation when he was at the Party Rand Graduate School using these data. What he showed was that in legally sold in stores in Washington State, the typical average THC potency for a high potency THC, which was by far the most likely product sold for flower material, was just above, the median potency was just above 20%. And this is a box and whisker plant, so you can see that there is some variation in what is being sold in the plant. As it is a plant, there's natural variability in this, but the typical potencies between the 25th and 75th percentile are 20% and higher, 22% for flower. That's flower. That's higher than what we saw in the illicit market. When we look at oils and concentrates, the actual potency sold in Washington State is even higher than that. Typical potencies of 70% THC. And today I can tell you, having just been in Lisbon talking about the international market, it's quite common even in the US to see potencies 80%, as high as 90% in some products. This is the median potency of what people are consuming, a substantially higher dose of THC than what occurs naturally in the plant. Even in the so-called balanced products, the average THC and CBD is in the 40% or higher range. This is a substantially different plant, as I said before. This is not the same plant that was being used in the early 1990s or back in the 1970s. It has been bred to have more expression of the THC, less expression of the CBD. The impacts of that on the body is what we're trying to understand. It's a large initiative that's happening in many more bench labs than what as an economist, I don't get it. I'm a consumer of this information, but I had to put up at least this one graph that indicates the range of different parts of our body and the different systems of our body that naturally are affected by endocannabinoids. When we talk about opioids and their impact on the body, we focus on the central nervous system and the ability of opioids to help regulate pain. And cannabis is often used as often talked about as a potential substitute for that. Yes, the science supports that could be possible based off of the impacts of cannabis in the brain, as well as in some of the other more further systems away from the brain. But what it's also important to know is our natural endocannabinoid system, which regulates cannabinoids that are produced in our body internally, naturally, as well as those introduced externally, are also involved in our digestive system. They're involved in our cardiovascular system. They're involved in our immune system. And so understanding how the cannabis plant impacts these body parts is really an important part of the science that hasn't been fully studied yet, in part because we just learned about the endocannabinoid system in the late 1980s and early 1990s. We are at the beginning of understanding the endocannabinoid system and whether the natural receptors are more likely to attach to THC versus CBD, or if that depends on which part of the body. So this is truly an emerging area of science, and we have lots to learn here. Nonetheless, in light of the impacts of the growing potency and what we do know of its impacts on the body, we are seeing certain outcomes in population health. There has been increased acute poisonings among children and adults, but this has largely been found in areas with commercial cannabis where there is an increase in this average potency of THC. Again, I keep emphasizing that because I really want to emphasize here, when I talk about the health risks, I want to talk about the risks of a particular cannabinoid being expressed in the product at much higher rates than what would naturally occur. Why? Not because I think the plant itself is dangerous, but what the industry is doing with this plant to generate a product that is, quote, desirable by consumers because of its ability to give you a strong intoxicating feeling or the like, is actually generating something that is more harmful than we would have naturally allowed if we just allowed the plant to be sold, for example. So there's growing evidence of acute poisoning and even acute psychosis Why do I say it's driven by these products? I think the best reason, the best data that supports this really comes from Canada and the Canadian experiment. Canada had medical cannabis for many years before it legalized adult use cannabis in October of 2011. And what I'm showing you here on this graph is the rate per 100,000 persons of unintentional cannabis poisons for children between the ages of 0 and 9. So these are children who are gaining access to cannabis in the house because they can't purchase it. This is just what's being found. And we're seeing very small, modest increases in the medical market in Ontario, which is the orange line, and in Quebec, which is the blue line, and a little bit of variation in Alberta and British Columbia, which get grouped together. Then in October of 2018, with legalization of adult use, there's a little bit of an increase. Importantly, in Canada, when Canada first legalized, it was only for flower material. That doesn't mean that edibles and other products were eliminated in the Canadian market, because they had been available in the medical market. It just wasn't broadly sold for lots of purposes. Then in January of 2020, Canada allowed provinces to decide whether they would allow for edibles and concentrates to be sold. And this is what we see happening to children's exposures to cannabis poisoning. Quebec, which was the only province that did not allow edibles to be sold in the market, continued to have a relatively small, modest increase in poisonings, whereas Ontario, Alberta, and British Columbia, which did allow for edibles and concentrates to be sold, saw a large uptick in these poisonings for kids. So how does this happen? Products get left out, they look like candy, kids eat them. This is not a reason to say we need to prohibit concentrates. This is an educational opportunity to make people aware, for kids at least. But it's not just kids that are being affected. I am showing here another slide that is focused on children, and it's focused in on Ontario, Canada, which is the most populated province in Canada. In Ontario, they had this dual occurrence in January 2020. In addition to the allowance federally for edibles and concentrates, Ontario went from a system that had fewer than, I want to say it was, I'm going to get the numbers wrong because it's been a while since I looked at, but a relatively small number of stores that were allowed in Ontario. In January 2020, they released the restriction on the number of stores that were allowed, and there was a huge expansion from less than a few hundred stores to more than 1,000 stores in a matter of 14 months. That increase in stores meant increase in competition, fight for customers. You see a huge rise of edibles, which is consistent with a big jump in poisoning that occurs for children. So we should be concerned, at least for certain products, and spillover effects for youth. But it's not just the youth. We're seeing it for adults as well. Adults who take an edible and think a candy bar, I'll eat a whole candy bar, and not realizing it's scored to actually only be 4 servings, not 1 serving. And they too have a accidental exposure. We've seen rises in Colorado for adult poisonings, just like youth, with the growth of the recreational market and these higher potency products. Psychosis, which is particularly even more concerning, has also been on the rise. I'm showing you evidence here from a study that I did with Sam Wang and my colleagues at the University of Colorado and RAND. Basically what we saw, and I'm focusing first here on psychosis per 10,000, this dark line here is the trend in this psychosis per 10,000 per county. So this is all counties in Colorado. Colorado, when it legalized both medical and then recreational, allowed for local jurisdictions to decide if they would enable retail stores to exist. Not all counties allowed for retail stores. The solid line here is showing you counties that did not allow for medical dispensaries prior to the legalization for adult use in Colorado, and stores opening in July of 2014. And then some counties had relatively few dispensaries, 1 to 9, that's the larger dashed line. Other counties, Colorado, Pueblo, a few others, had large number of dispensaries, and that's the dotted line. What we did was compare what happened to the rates of psychosis to patients who lived in the counties that had no prior medical exposure when legalization occurred and that county decided to open a rec store for the first time. And what you can see is there's an enormous jump initially in those counties that had no medical exposure previously, largely due to patients using a product not being fully informed of the potential risks, whether it's an edible or a concentrate, and having an acute reaction. So these are acute psychoses. These are important public health events, but these are events that we can provide education to fix and change. This is not something that we have to regulate necessarily if we have effective education that is going to the consumer. But it's not just the acute psychosis that is a concern. What I'm showing you here is evidence from an international study that was examining individuals who used cannabis over time. It was a longitudinal case control study, looking at individuals controlling for age of first use of cannabis, and frequency of use, and what the rate of experiencing a subsequent psychotic disorder based on the frequency of cannabis use and the level of potency. And what's interesting here is the green line is the control group. The red line is the, wait a minute, I think I'm just explained that. I'm sorry, wrong. The green line is the unadjusted odds ratio difference between the treated group and the control group, the treated group being those that used a specific level specified below. So never used is your reference group, odds ratio of 1 for relative risk of psychosis. There's no difference. As you move right, I'm showing you rates of increases in use of low potency, less than 10% THC, more frequent use of low potency THC as shown here, and then here, every in between. And what you can see here is unadjusted, there's higher risk, and that's what we have been seeing in lots of studies. But in more careful case control, the actual adjusted odds risk of getting a psychotic disorder after even frequent use of cannabis, when it's low potency, still includes 1 as part of its confidence interval. Low potency cannabis does not drive the risk of a psychotic disorder. High potency, as defined by the researchers in this study, which is only 10% THC, had a much larger odds, almost a 5% higher odds after adjusting for frequency of use and age of first use of a psychotic disorder. So the potency of cannabis, the product that is being sold, think of this like the difference between drinking a glass of wine or shots of, I want to say, Everclear, something that is much more potent. It's very obvious to any of us who've done alcohol research that those are very different products, very different health effects, and hence probably should be treated differently in our legal system, and in most states are treated very differently and should be studied differently. But we are only just now beginning to understand how to get information on what the individual consumed. It's not how frequently did you use the cannabis, it's what was the potency of the cannabis that you were using. The closest proximal way of doing that is looking at product choice. And I'll get to that in just a minute. So we know there's increases in acute poisoning, there's increases in acute psychosis, and among people who use higher potency products, increased risk of a psychotic disorder developing. There's lots of evidence of an increased risk of addiction because this higher potency THC is also much more addictive. Early cannabis studies that looked at early cannabis plants suggested the lifetime risk of it, the risk of a lifetime user becoming dependent on this lower potency product was really, really low, which is part of the reason why people really thought this is just not a product that we should be prohibiting. When you look at the higher products being sold today, the research today is suggesting a much higher risk of a cannabis use disorder. 22% of people who use in the past year are likely to become dependent. And that's because of the higher potency of these products. It's not just a problem of addiction and mental health. As I mentioned earlier, the body has endocannabinoid system that regulates many different parts of our digestive health, of our heart health and the like. There's growing interest in what we refer to as cannabis hypermesia syndrome, which is not an ICD-9 or 10. This is not a diagnostic code that we can go and look at in healthcare data, unfortunately. This is unfortunately a condition that we have learned about because of individuals continuing to show up in the emergency department showing symptoms of cyclical vomiting, needing to get lower GI tests. It's a whole battery of gastrointestinal exams done so that we can identify what's going on. And there's nothing that seems to be identified in those exams. What happens is through conversations, finally somebody asks, did you by chance use cannabis? And the person says yes. And they give them a hot heating pad and put it on their stomach and all the symptoms go away. This is how we identified cannabis-induced vomiting or cannabis hypermesia syndrome. And what I'm showing you here is a graph from a study again in Canada using that experiment at the introduction of the more potent products, showing that cannabis-induced vomiting doesn't happen the first time you use cannabis. It doesn't happen the 10th or the 12th. It evolves because of a persistent use of cannabis over a frequent period of time. They're saying about 9 months, but we don't know exactly because, again, it depends on the products. It happens more earlier, after repeated use earlier, when it's higher potency products. And again, we saw in Canada with the introduction of legal flower, just the growing increase in cannabis hypermesias that we had seen before. These are people who are not having acute problems of cannabis, but are using more persistently, are now having gastrointestinal problems associated with this use. And it jumps tremendously with the introduction of the higher concentrates. So we know that this is part of the problem in our body's ability to regulate this issue. We see the same thing in Colorado. Here I'm showing you again in black, the counties that had no medical exposure to cannabis before legal recreational use in Colorado, and then what happens to this vomiting related ED visits after they adopt recreational stores. It becomes on par with the counties that had medical and recreational stores previously. In Colorado, we can't do as good a job as saying, is it the higher potency product or low potency, because we don't have any differentiation in the market. All we have is the policy variation, not the product variation. So there's other risks that we should be concerned about. Risk of use during pregnancy. There's several studies showing a rise in increased use. And again, if there's also increase in potency of the cannabis being used, that's a problem. Unfortunately, we have the cannabis industry that is marketing to pregnant women that cannabis is a great way of dealing with nausea associated with being pregnant. There's no scientific evidence supporting the benefits of using cannabis for pregnancy-related nausea, and there's evidence of potential harm to the fetus. Again, I say potential because the studies have not been done in a detailed way to be able to identify what type of cannabis products are these individuals using. If it's very low potency or if it's CBD only, there might not be the health risks associated, which is why this is such a fun and challenging area of study. There's evidence, and I say evidence, I'm not saying definitive, of risk of impairment in work, with work accidents, in school, schooling outcomes, impairment driving. And then there's a whole bunch of research that's very interested and has demonstrated some potential substitution relationship with making cannabis more available and possible reductions in opioid use, as well as reductions possibly in alcohol use. A really recent study by Dave and colleagues published in the NBR suggesting even a decrease in tobacco smoking, which makes cannabis sound like it's the wonder drug for curing a lot of the other public health problems caused by other substances available in the market. That's not how I worded this, though. I said increase in use. And let me explain why. I don't have to do the full explanation. There was a really great paper produced by Theodora Caputi that talked about the inconsistencies of the evidence showing how medical marijuana laws could be responsible for up to a 25% reduction in opioid overdose deaths, a 2.1% reduction in obesity, a 10 to 20% reduction in opioid prescribing, 15% reduction in alcohol sales. These are the wonders of cannabis policy. The problem is this: the actual number of people, registered patients who use cannabis medically, even in legalized in medical states, is just way too small to generate these sort of large effects that we are seeing in aggregated state level data, which is why some have argued there's the concern of ecological fallacy. And in fact, several studies that have extended time periods are finding, particularly in the case of opioids, a complete reversal of the finding from medical marijuana laws. I firmly believe that this is not a yes/no question. There are different individuals using different products for different purposes. We need the careful science to know, in some cases, what variants of the cannabis product are helpful for medical patients in reducing the amount of opioids that they are using. Very few studies have, except for patient self-report, have said that cannabis use eliminates the need for opioids. Patients report that, but we have yet to see it in the lab with rats and with people. There's a reduction in the amount of opioids used, and that is a good thing, but it's not an elimination. And that reduction so far, worked by Yasmin Hurd and others, has shown that it's only short term, that it actually gets corrected over time because patients develop tolerance just like they do to other substances. And so the ability of the marijuana to reach opioid is actually declining over time. With respect to alcohol, the literature is actually much more complex than what the industry or advocacy groups on either side will argue. I was part of a comprehensive review updating a very careful review that was done in 2015. And even with more recent studies as of 2020, there's just no clear evidence of the relationship between cannabis policies and alcohol use. In part, fundamentally, I believe the reason why is because you have a heterogeneous population. Some age groups will use them together and they will be complements. Other age groups will use them as substitutes. And when we do these studies, we aren't paying attention enough to the populations or the products being consumed. So I'm going to be running out of time here, but let me make 3 points about why I'm so cautious in understanding and trying to draw conclusions from the public health literature. The first is that bench studies that have been done evaluating the positive and even the harmful health effects associated with cannabis have had to rely, because of our federal prohibition, on cannabis supplied by the National Institute of Drug Abuse, grown at the University of Mississippi. And the typical potency of that THC is between 5 and 7 milligrams. So the studies that we do in labs with careful dosing, where we know what people are taking, are using a product which is substantially different and much lower than what we have available in markets today. So our bench science is not yet able to inform us about what the impact of current available products produced by the industry can do from a public health perspective. Secondly, observational studies are just blind to which products people are using. Our surveys, the BRFIS and NISDA, Monitoring the Future, are just starting to ask, do you vape the product? Do you use an edible? But that still doesn't tell us the content, except for in the case of edibles, which are standardized. There's 10 milligram THC doses in most edibles sold in the US. Only one state requires it to be lower than that. So we don't have a standard product. When we talk to drinkers and say, did you drink last night? If it was a Friday night and you had 6 drinks, you saying I drank last night doesn't tell me the same information as if I asked you on a Tuesday night when you had a glass of wine. We need better data. We're just starting to get it. And as we get it, we will become more informed of what the public health benefits and the negative consequences are. And finally, for all those studies that have been relying on the state variation to identify the impacts of these policies, fundamentally, there's been a reckoning in the economics and statistical literature of the primary statistical workhorse for these studies, differences. basically what we've identified is that because of rapid policy changes that are happening, and because the treatment in these states is dynamic, markets open, new products develop. The new products developing are happening simultaneously with new markets opening across states. That generates heterogeneous effects in these markets. Those two problems generate biased estimates of the average treatment effect of these policies. And so many of these prior studies are now being redone using new methods that try to deal with this average biased treatment effect. And I can tell you one really prominent and important study done by Chris Room and his colleague at UVA showed that when you correct for this bias, all of the relationship between medical marijuana laws and opioid mortality disappears. So part of the problem is the quality of the science that we're bringing to bear on the study. I have a lot more that I could say, but I know I'm running out of time and I do want to leave time for questions. So let me just close with a few items. One, we have a problem with the current US system because we have dramatically falling potency adjusted prices. And what I'm showing you here are prices in Colorado alone, where they have relatively good data. And for the typical average dosing to edibles, 10 milligrams. Oh, by the way, flower, they're showing flower and concentrates at almost 60% THC. The prices for even these high potency products has been declining and is now well below $2 per dose of THC. When you talk about alcohol and you talk about tobacco, one of our primary tools for reducing public health harms are higher prices. And with legalization, the modification that's happening to the production process has generated declining prices well below what we can tax our way out of. The second problem that we need to be thinking about is that the current regulatory environment in the US has been enabling rapid product proliferation of these higher potency products, and they're getting marketed to everyone. The plant is increasing its potency, the derivatives of the plant is increasing in its potency, and these products are being infused in a variety of products that are used by multiple individuals. So I'm just going to jump to my key takeaways and conclude with this. Cannabis is a very complex plant. There's multiple cannabinoids in it that have both positive benefits and negative benefits to our health. We're learning about it as we study the endocannabinoid system, and we're going to have lots to learn. But this is not a single product. When you think of cannabis, think of dairy. And this is an idea that comes from John Calkins. I can't take credit for this. But dairy is a class of products. And there's really healthy products in dairy like yogurt. And there's really unhealthy products like ice cream. Does that mean dairy is bad? No. It means there's a product range that we need to think about, and we need to study the full range. The states can be doing more to protect public health by paying attention to the fact that this is not a homogeneous good. Set up an environment that pays attention to the potency of the products and reduces the likelihood that the industry can target individuals to use higher potency products than what would be healthy for them to use under normal circumstances. We want to encourage a legal environment that promotes moderate use, not excessive use. And then finally, US researchers have to be really careful conducting research in the US. We can learn a little bit from abroad. I was showing you studies in Canada, but what I didn't get to tell you is that the average potency of products in Canada, the maximum potency that can be sold in a whole edible product is 10 milligrams, not one serving. A whole edible product in cannabis is 10 milligrams. Flower has a lower average potency. Concentrates are restricted to 60% THC. So when I showed you those health events associated with poisoning and cannabis hypermesis, these are lower potency products than what we observe in the US. And we need to be aware of that when we try to learn from lessons that are of experiments abroad. And with that, I'm going to stop because I know we'll have questions.
All right. Well, thank you very much for that very engaging presentation. I know I've been taking notes, lots that we can learn, lots that we can think about in our research and in our public health education, and so forth. I will be managing the Q&A, and I did see Andy Highland had raised his hand.
Andy.
So Andy, do you want to start us off with Q&A? Oh, just a minute. Our technical supervision is
Andy and I go way back.
Catching up here.
As part of the Impacting initiative when we were both very junior.
Okay, I see Andy. You're gonna unmute. There he is.
There he is.
Rosalie, fantastic talk. So much experience, practical, real world. So the comment that, or the question that I'll have is, you did bring in a number of references to tobacco, alcohol, and even other areas. I love the dairy example. And you maybe succinctly maybe give one example, say for each of tobacco and alcohol, how we can apply some significant lesson learned in tobacco or alcohol in the cannabis space, while recognizing that cannabis is different. And so that it's not like, oh, we're just going to run the alcohol playbook and then put that over there. Even just one example will be wonderful. I would appreciate it.
I have 4 for you, Andy. Because this is a very important point, and it was something I didn't get to. So from alcohol example, many states have limits on the ethanol content of alcohol that can be sold in, say, a grocery store versus a liquor store, and on what day a week those can be sold. We could do something similar for cannabis. We could, instead of allowing a naive person who's just interested in exploring cannabis, walking into a dispensary and being introduced to the mammoth 120 different products available, have certain products available in certain type of stores and more higher potency products for regular users who maybe are less likely to have a negative reaction because they've been using for a longer time, go to a different store. That would be one lesson learned from alcohol that I think would be very easy to apply to cannabis, and I'm surprised hasn't been thus far. In the case of tobacco, I think it's really more this issue of limiting the types of products that can be sold in stores in general. We are very careful about where you can place vaping products, high nicotine products out of reach of children that can't be near any marketing material and the like. None of that exists in the case of cannabis. And more importantly, while kids can't go into stores, this is one of the things that always shocks people. A bright colleague of mine, Union Shi at UC San Diego, did a wonderful study of over 700 dispensaries in California, and basically was checking to see if they were compliant with this youth access, right? And they're all very good at checking the age, but some of them do it inside the dispensary. Over a third do it inside the dispensary, in the waiting room. They can sit in the waiting room, they just can't go back to the sales room. And in the waiting room is all this messaging from the industry about the new flavors, the new products, the new tools. So the kids can be exposed to this while their parent is going in to actually look at the product. This is something that we can change. This is an easy thing to fix. And of course, potency-based taxation would be a really valuable tool. Only a couple states so far in the US consider that. In Canada, there's a simple sales tax price on flour, but concentrates, there's a potency-based tax on concentrates. They have already adopted a more sophisticated system, recognizing that these are different products. In the US, there's a few states that are starting to do this. Illinois, for example, has a 10% tax on anything below 35% THC, and then anything over that is a 25% tax, but that's still flat rate taxes. That's not scaled entirely with the potency. So I think that's another example of something that we can do very effectively in cannabis to help improve even if it doesn't eliminate the risk because we have collapsing prices in cannabis, it at least sends a clearer message to a consumer and entices them perhaps not to spend a lot more money on the higher taxed good. And if they're just interested in enjoying an evening, maybe go to the lower tax product.
Awesome. Thank you. Fantastic work. Great to see you, Rosalie.
You too.
Okay, I'm seeing comments on the chat. And one thing I wanted to mention is that the marketers make products that directly appeal to
Yes.
children. So, you know, it uses their favorite cartoon character, or the gummies are made to look like candy, and
The
so forth
Twix,
and
the
so on.
Pot Tarts, and in no state, every single state prohibits the marketing of products to children. And yet these products are still being sold in the stores.
Right. Okay, so we've got
So a big piece has to be compliance checks and using some of the tax revenue to support compliance checks, which hasn't been done aggressively in every state.
Oh, yeah, the variation among the states is mind-boggling.
Yes.
Ritu Biswas asked two things. Which of the four options would be the most effective of the four options that you just described? And then she followed up with, do you think a regulatory or an educational intervention to reduce the use of cannabis would be useful?
So it's an interesting question, because I do think that placing caps on the amount of THC in products, or that can be sold in legal products, could be a very effective way of regulating a legal market. The problem with that is it's going to induce people to go to an illicit market.
Right.
I do recognize that as an issue, but I also recognize that the people that it's going to induce to that market are the people who are currently consuming the higher potency products. That's what they want. And what you're doing is you're setting up a norm for new users who are growing up in a world where they have dispensary stores around them and they're seeing it in TV and other places. You're introducing them to a legal market where it's product is available that's much less likely to cause negative consequences. I don't think limiting the illicit market is going to be achievable in any world. So I think that using a cap and setting up a regulatory framework that is promoting moderate consumption is worth the risk of spillover effects into the illicit market, because I don't think the illicit market's going to go away anyway. That was the first part of the question. I missed the second part. I'm sorry. Oh, you're on mute.
Yeah, the question had to do with educational intervention.
Yeah. I don't have a whole lot of faith in the education interventions in a world where the industry is allowed to market the way they have market. They've been working at this already for 10 years. They have a lot of money in this. I think whenever we do education, we have to be honest in the science, and the science is not perfect, and the science has lots of holes. We can't cherry pick the science when we do an education campaign, because then we're not being honest. How well did the Truth Campaign work on youth? It worked very well, but we had decades of science supporting that. We don't have the decades of science supporting it for cannabis. So I think we need to be honest in what we know and don't know, honest about this being both a helpful plant and a potentially dangerous plant, depending on what's being expressed from it. And then do our best to be able to reach into the stores where people are making those choices, and not have it being the bud tender who's paid for by the industry recommending a product, but instead have doctors, have public health officials, have a campaign about the products so that people have better awareness.
Okay, thank you. So here's a message from somebody you probably also know, which is Gary Giovino.
Oh, Gary, the tobacco crowd is here today.
So Gary asks, can you explain more about the thinking that considered a link between state legalization and deaths from opioid, and how that disappeared with proper control for relevant variables?
So this is going to be your statistics course, Gary. Sorry about that. But basically, I didn't do a very good job in explaining it so quickly, but difference in differences is a wonderful tool when you have all the treated groups adopting the policy at the exact same time. And the effect is generally the same in the exposed group because they don't have differential exposure to the alternative but similar policy like medical cannabis. In the case of the US, every single state that has passed legal adult use had previously had medical use, but they had differential length of time of medical use, and they also had differential experiential market. Colorado, California is a very different medical market and looks a lot more like an adult use market than New York or Massachusetts. So the medical markets there are different exposure than the medical markets in Colorado and California. So transitioning from medical market to legal market is going to be different in those different states. Our traditional methods could not account for that difference in treatment effect, and new methods are being developed. There's a lot of great work that's happening, and Gary, I'll send you the statistical references because I'd say it's a lot more to get into than some of this crowd would probably be interested in knowing.
So we're going to end the formal presentation with the next question, but Dr. Pacula is available for those who want to stay and continue to ask questions longer. So this is one from Bill Wyzorik at Pyre, and he wants to know, what do you think of a policy to limit legal edibles to unflavored gelatins? It would eliminate the kids focused marketing as well as children thinking they're eating candy. I'd love to hear what you think about that.
Yeah, I think it's a good idea. I think you're going to have the same exact pushback that you get from the tobacco community with vapes when they say, the established smokers who are trying to quit combustible smoking and they're moving to vaping and they just prefer those products. You're going to have some of those same issues argued by adult consumers of medical or even adult use edibles. I think that the difference is this: we have traditions, fairly recent traditions in the last 30 years of people purchasing cannabis and baking brownies at home. There's nothing with legalization, a moderate flower potency that would preclude you from going home and making brownies yourself. With that, I think it changes the argument, but again, it's because you have to think of cannabis as a very different product than an alternative to smoking or a smoking cessation device, which I have heard from some public health advocates, even in Europe, in part because the product available in Europe is very different than the products available here.
All right. Are there any other questions? I'm not seeing any. So at this point, I would like to formally thank Dr. Rosalie Pacula for a very engaging talk. We really appreciate all that you've shared, and we will try to contribute to improving things.
There's lots of room, and
yes.
I can tell you, NIH has got many calls for requests for good work to try to help build the science that we need to develop strong public health campaigns.